Okay, so let's talk about arrhythmias, also known as dysrhythmia. Okay, so let's talk about arrhythmias, also known as dysrhythmia, same thing. Okay, we're talking about the EKG and the abnormalities of it. Now, I'm not going to do this kind of like a crash course on abnormalities. There's no way I could actually talk about all the different arrhythmias. But you should have some knowledge of them, because when you get to pharmacology, if they talk about heart block, you should have some idea what that is. Atrial fibrillation, have some knowledge of that. But we're not going to go into the details of that. It's just like an overview of them. Whatever is in these videos, or I'm sorry, in the videos and also in my PowerPoints, that's fair game for my exam. You don't need to go further into the textbook. As always, the textbook goes more into other things, and if you have an interest in it, by all means go that way. If you're confused at what I talk about here or what's in my PowerPoint, by all means use that as a supplement to the textbook. But I'm not going to go into all the different ones on it. There's too many. Okay, so you should have a basic knowledge on EKG. If you don't understand what an EKG is, or the blood flow through the heart, or the electrical impulse going from the SA node to the AV node to the bundle KISS to the bundle branches left and right to the Purkinje fibers. If you don't know that order and where they occur, don't go into all this, because it won't make sense to you. You've got to understand what it looks like normally. As we said before, you know, you can't know abnormal, you can't study abnormal EKGs if you don't know what a normal one looks like. All right, don't go right into the diseases if you don't know how anatomy and physiology works. Okay, you can't look at abnormal chest X-rays first and then look at what a normal one looks like. It just doesn't work that way. It doesn't, you know, you got to understand how to do the studying properly. Okay, so just a quick, my first few slides, the first 50 or so slides, has more details about a review of EKG. I'm giving you even a smaller version of my review for it right now, okay, just so you can see it. But basically what we have here is a normal EKG. The three major parts on here is a P wave, QRS complex, and a T wave. The P wave is when the SA node fires, the one that's in the right atrium. It fires. If that fires, then both atria will contract, okay? And that's what happens with a P wave. The next phase that goes over is the QRS complex. The QRS complex is where the ventricles contract. Now, that's also the same time that the atria relax, but because the contraction of the ventricles is so strong and massive, it masks, it hides the actual relaxation of the atria on the EKG. So you don't see the atria relax on the EKG. It doesn't show there because of such the high QRS that's happening over there. But it does occur at the same time. In other words, atrial relaxation occurs at the same time as the ventricles contract. Okay. Then we also have the ventricles relaxing, and that's what the T wave is. So what I'm showing you over here is this is an EKG, here's an EKG, and so forth. So we have a P wave, so this is where the atria are going to contract. Then you have the QRS, which is where the ventricles contract, but also in parentheses where the atria relax. And then you're going to have the T wave, which is where the ventricles are going to relax. Then you'll have another EKG happening and another one and so forth. Okay. Now, keep in mind, we should always see with every P wave there should be a QRS. For every atrial contraction, there should be a ventricular contraction, right? And then you got a relaxation. Atria contract, ventricles contract, ventricles relax. Atria contract, ventricles contract, ventricles relax. Atria contract, ventricles contract, and ventricles relax. Again, atria do relax, but it's hidden in this massive complex that happens in the QRS. Okay? So you should understand those. This here, take it a few moments, but this is actually an animation that happens, and you can actually see this occurring, okay? And you can see where the, if you follow the SA node to the AV node, to the bundle His, to the bundle branches down the interventricular septum, to the Purkinje fibers, you can see where the electricity all happens. And you can see what happens to the heart as the electricity happens, okay? So again, this is a quick review about the EKG. Okay?
The heart generates pressure gradients that drive blood flow through the vascular system. Although the heart appears to be a single structure, it is divided by a central septum into two separate pumps, each consisting of two chambers, the atrium and the ventricle, that alternately contract and empty during systole, then relax and fill during diastole. The timing of the electrical and mechanical events in these chambers must be precisely controlled to ensure efficient cardiac function. The timing of atrial and ventricular contractions relies on two primary cell types: cardiac myocytes, which do the mechanical pumping, and autorhythmic cells, which initiate and conduct electrical impulses that drive contractile activity. Autorhythmic cells cyclically depolarize on their own, then fire an action potential each time they reach threshold, a process known as pacemaker activity. This activity originates from primary pacemaker cells in the sinoatrial or SA node in the upper right atrial wall. The pacemaker potentials swiftly move through the interatrial pathway to the left atrium and spread throughout the atrial myocardium via gap junctions. As a result, both atria depolarize and contract as a single unit. The impulses generated by the SA node also rapidly spread through the internodal pathway to the atrioventricular or AV node at the base of the right atrium. The AV node is the only point of electrical contact between the atria and ventricles. Here, the impulses briefly slow, allowing the atria to contract and empty their contents into the ventricle before ventricular depolarization and contraction occur. The impulse travels quickly through the bundle of His within the interventricular septum. The bundle branches into smaller Purkinje fibers that radiate throughout the ventricular myocardium. Action potentials travel quickly through the Purkinje fibers, then spread to the surrounding ventricular myocytes via gap junctions. Depolarization triggers contraction. Repolarization triggers relaxation. The swift spread of the impulse through the specialized conduction system ensures that the ventricles become excited and contract as a unit. The spread of cardiac electrical activity may be recorded using electrodes placed on the body's surface. The recording, called the electrocardiogram, or ECG, has several distinct components. The P wave corresponds to atrial depolarization. The QRS complex appears with ventricular depolarization. The T wave represents ventricular repolarization. The P wave initiates atrial contraction, which completes ventricular filling. The QRS complex initiates ventricular contraction, which pumps blood out of the heart. During this time, the atria repolarize and relax. The T wave initiates ventricular relaxation, during which the ventricles fill once again. One cardiac cycle is complete.
All right, so with that, let's go into arrhythmias, okay? Again, arrhythmia, dysrhythmia, same thing, all right? Basically, it's any type of irregularity in the heart rate or the rhythm of the heart, okay? You gotta get EKG about this. EKGs is the best diagnosis tool to pick up on any arrhythmias, all right? And there is many causes of this. A lot of them could be idiopathic. Some of them, believe it or not, are medications that can cause this, okay? And certain medications will help remove them. So again, pharmacology will go into the details of those. Now the definition of bradycardia is any heart rate that is less than 60 beats per minute at rest. We call that bradycardia. Brady meaning slow, cardio meaning heart rate, so it's less than 60. I do want to make note on here, well-conditioned athletes will have a normal blood or a heart rate of less than 60. All right, their heart has been conditioned to that. So for them, it is normal. All right, but in someone who's not an athlete, like me, if my heart rate is 55, we call that bradycardia. Okay. Tachycardia, again, tachy means fast, cardio means heart rate. We're talking about a heart rate that's over 100 beats per minute at rest. That's the key thing, at rest. Okay? You ask me to run a marathon or just run to the corner of the block, my heart rate will go to 120 beats per minute, but I'm not at rest. Does that make sense? This is like right now, if your heart rate is 140 beats per minute and you're just listening to me talk, sitting there over there, that's tachycardia. Okay? Certain things can cause that. Medications, a lot of things can cause that. Medications can cause that. You just being stressed about something, like a certain disease. Even a fever. A fever will make the heart rate go faster too. So even if you're lying there and you've got a fever 120, not 120 degrees, I said 102 degrees Fahrenheit, your heart rate might be like 110 beats per minute. Okay, it's just the way your body's trying to compensate, getting the blood quicker to those infected areas. Okay. Now the word sinus means that for every P wave, there's a QRS. Okay. For every QRS complex, there's a P wave. For every atria that's contracting, we should have the ventricles contract. So we say that if you see like the one I showed you just before, if you see a P wave with every QRS, we say it's sinus. Okay. So this is showing an example of what we call sinus tachycardia. I'm not going to ask you, it's AP2 stuff, but I'm not going to ask you how do you figure out the heart rate, all right, that's old stuff. But what I would ask you is, if I give you this, is it sinus or not, right? So you could have, like, here's a P, here's a QRS, that's a T, P, QRS, T, P, QRS, T. So for every P wave, there's a QRS complex. All right, so even though this is fast, over 100 beats per minute, it's tachycardia, but it also gives us more information calling it sinus tachycardia, that there isn't anything wrong with, let's say, the P wave or the QRS. Okay. Now, keep in mind what the P wave does. The P wave is when the SA node, known as the pacemaker, fires. So you could have a situation here where there is no P wave. See? That's a T wave from that, but there's no P. But you have a QRS complex, a T, QRS complex, a T, QRS complex, a T. Their heart rate will go slower. What happens here is that if the SA node doesn't fire for whatever reason, the AV node, which is also in the right atrium, is going to take over. Now, the SA node beats normally at 70, 80 beats per minute. If the AV node takes over, it tends to do 40 to 50 beats per minute. So they will have bradycardia. But if you do an EKG, you will see bradycardia. The beats are much slower. But the other thing you'll notice is that there is no P wave because the SA node is not firing. How do you fix this? Well, you'll probably have to just give them an artificial pacemaker. Okay, something they put together, I think, in the 1960s. Artificial pacemaker is that they're going to put this little thing that's going, it's about the size of a Zippo lighter, about that big. They've gotten smaller, but they're about that big. Not as thin. I mean, not as thick. It's thinner than that. Maybe the size of maybe 2/4 thickness, so to say. Anyway, so they put it underneath your skin, so it goes subcutaneously, it goes under your skin, and there's a wire that comes out, and it will go into the ventricle. That's what it looks like, by the way, but it goes underneath your skin. And then the electrode goes down into towards the apex of the heart, which is in the right ventricle, all right? And it fires, and it shocks that heart to make sure that that heart is not going to skip a beat. And this is up at a certain pace to make the heart rate go at a more efficient way. That usually stays in. They've gotten better. I think they stay in. The batteries are now for like 5 or 10 years. I'm not too sure. And then they have to remove it and put a new one in and so forth. But that usually resolves the whole thing with someone who doesn't have a P wave, and it goes right back. Okay? So that's what's going on with that. Okay, then we have something called a flutter. Okay? A flutter is a fast heart rate, usually 240 beats per minute to 360 beats per minute, not higher than 360. And it usually can happen in the atria or the ventricles. And the heart doesn't have time to fill. It's coordinated. It's regular. So what happens here is that you have a flutter. Basically, if it's the atrial, and that's what is shown over here, you'll see a couple P waves or something. There's something going on over here, and then the QRS, there's the T, and something like that. But you can see a nice, distinct, a few P waves. But we don't call them P waves. We call it a flutter. There's like a bird would flutter up, right? So flutter, flutter, flutter. And that's what it is. The problem is the heart doesn't have time to fill with blood before the next contraction. All right, and that's why we got to try and figure out what's going on with that. A lot of times it won't be the whole thing. It might just be, for 10 minutes and then goes away for, let's say, a week or a month or something. Or it might happen a few times in a day. But that's what we call a flutter. Okay. The problem is with and this is atrial flutter. Some of these can lead to what we call atrial fibrillation. And that's something we've got to figure out, what's going on. We've got to fix something on there. So that's a flutter. The key thing there is that it's a very fast heart rate, usually 240 to 360 beats per minute, but it's coordinated. Okay? It's regular, that we see like the same amount here, the same amount here, the same amount here. It's coordinated. Okay? And you can actually see the actual P waves, so to say. Okay? Now, fibrillation is very fast and it's uncoordinated. Basically, it's like your heart is quivering. It's kind of like think of a bunch of worms in your hand, and then the worms are just moving all around. There's no coordination whatsoever. Right? That's what's happening over here. The heart is quivering. And it can happen in the atria or the ventricle. And blood tends to stagnate. Because it's doing this, it's not really giving a nice push of blood forward. The blood is stagnating in that, let's say the atrium, it's stagnating it's creating that eddy, so to say, right? It's almost like an aneurysm, but it's not an aneurysm, but it's making the blood sit there. It's not moving forward, so it stagnates, and because of that, the platelets will clump together and form a clot. Now that can actually get pushed forward. If that's, let's say, the right atrium, then that's going to go from that clot can go from the right atrium to the right ventricle to the lungs, and now you've got a pulmonary embolus that was due to a right atrial fibrillation. Does that make sense? If you had a left atrial fibrillation, what we see more commonly, then that will force a clot to go from the left atrium to the left ventricle to the aorta, and a lot of times it'll go right into the brain, right? It'll go to the carotids, right into the circle Willis in your brain, and that's what's going to happen over there. So we got to, usually with people with fibrillation, we got to treat them for antithrombolytics. In other words, we got to treat them so that they don't produce these clots. Okay? So atrial fibrillation, there's no definitive P wave, and I'll show you. You're not going to be able to see that over there. The only fibrillary waves, there's only fibrillary waves in between the QRSs, and they're higher than 360, and they can go as high as 600 beats per minute, okay? The treatment, like I said, they're going to try to prevent those clots from happening so you won't have a stroke, if it's in the left atrium. Or if it's in the right atrium, the fibrillation, then you'll form a clot going into the lungs, right? Again, you need to know the blood flow through the heart before you understand all of it. So that's what's happening. We refer to it as, a lot of people just say AFib for atrial fibrillation, okay? So this is atrial fibrillation. See, the QRSs are quite defining right there. But here, you can't even see the P waves. There's just some quivering that's going on over here. Does that make sense? Okay? So that, it's going so fast that we can't even see a definitive P wave. All right? So that's what's happening with that. All right? So that's atrial fibrillation. Ventral fibrillation, this is probably one of the most life-threatening EKGs that you will see. You don't want to see this over here. This is where the heart is unable to pump blood. So you have, remember, most of the time for the blood going from the atrium to the ventricles, it's just a passive thing. 70% of the blood is going to go right there just because of gravity. If you want to push that other 30%, then the atria need to contract. So that's why we need to, we don't really need to do much for atrial fibrillation because most of the blood has already gone into the left atrium, or left ventricle, okay? However, for the ventricular fibrillation, we got to make sure that the blood goes into the aorta, if we're talking about the left side, right? So we need to make sure it's going to go into the aorta. And when you have this, like I said, the handful of worms that's happening with the ventricle, you're not going to be able to push that blood forward. So you can't see any definitive QRS over here, let alone P. I don't even know where everything is. This is very scary. When you see an EKG that looks like this, that there is no defining P wave, QRS, T wave, we call this ventricular fibrillation, VF or VFib, okay? The heart is unable to pump blood forward. These people here will have no pulse because the blood can't be moved forward. You're not going to feel a pulse in their arm or anywhere. There's no blood pressure because you can't get the blood up there. There's no respirations because usually the blood can't even leave the lungs, okay? And there's really no heart sounds because it's just quivering going there, not a strong heart, like a closing of the valves or anything. So these are very scary. This will lead to cardiac arrest, a myocardial infarction, if it's not corrected in 3 to 5 minutes. So there's certain medications you give, you'll do the CPR, you'll do all that kind of electrocardio, all those things which I don't want to get into. But basically, it has to be corrected in 3 to 5 minutes, otherwise the person will die. They will go into cardiac arrest, okay? Because keep in mind, yes, blood needs to go into your brain, the kidneys, and intestines, but also blood needs to go into the heart muscle, into the coronary arteries. And if there's no blood going into the aorta, you're not going to get any blood into the heart muscle. Premature contractions. They're also called extrasystole, right? Systole means contraction. So you have an extra contraction. Sometimes we call them ectopic beats. Ectopic, I know people think like ectopic pregnancy, which is good, but ectopic means not in a normal place. So when we talk about ectopic pregnancies, it's not in where the uterus is. It happens, it's a pregnancy that happens outside the uterus. Well, same thing here. This is a beat that happens outside of where it's supposed to be occurring. So we sometimes refer to them as ectopic beats or extra contraction, extrasystole. So premature contractions. A contraction that happens prematurely, something that does, it's supposed to be coordinated, it's not. One or more extra contractions within one cardiac cycle. We shouldn't see another one there, right? It basically will disturb the amount of blood leaving the chamber because now, you know, it just squeezed. So think about this. So you have here's your atria, here's your ventricle. So your atria is, I'm going to do this very slow so you can see it. So it's going to contract, this is going to receive, now this is going to contract, but then another one, but then as this is contracting, this is going to, the atria is going to contract again while the other one's contracting. It's uncoordinated. Does that make sense? Okay? So it disturbs the amount of blood leaving that chamber. Okay? Most are innocent and unnoticed, and unnoticed if it's infrequent. Some patients perceive this as palpitations. They feel as though their heart is beating, like without even feeling their chest. They can say, "Ooh, what was that?" and that kind of thing. Most of the time, they're usually just innocent. It's just one ectopic beat that happens. You skip the beat, maybe you saw a loved one, that kind of thing. But you see, it usually gets resolved by itself. It's usually an innocent thing. It's when they get more frequent that we're more concerned about. So we can have a premature contractions happening in the atria or the ventricles, right? So we have premature atrial contractions. They're referred to as PVCs, and that can be due to ethanol, all right? The ETOH is a fancy word that you're going to see quite often, alcohol. So alcohol use, smoking, caffeine, stress, a post-myocardial infarction, infections, and the list can go on and on. It might just be idiopathic, right? All right? Usually does not require any kind of treatment except avoiding the causes, right? So, you know, if you're drinking alcohol, you're smoking, you're doing a lot of caffeine, coughing, so you just avoid those things, and that should just relieve the areas. Premature ventricular contractions, PVCs, okay? This is the most common arrhythmia occurring with an MI. Make sure you see that. You're going to see PVCs quite often, or hear about them later on. Basically, it's the same causes as premature atrial contractions, PACs. The treatment, because they're ventricles, the treatment, again, if there's no symptoms, we're just going to try to avoid the causes, the alcohol, the cigarettes and stuff. If there is some kind of symptoms, like palpitations they feel or something like that, or they're getting tired, then they'll give some kind of antiarrhythmic medication, which again, I'm not going to go into. It's a whole chapter when you get into pharmacology. All right, so that's what's going on with that. And this is an example of premature ventricular contractions. They kind of look like this that happens in here. It's a darker area here. There's a darker one over here. And there's one over here. All right. I'm not going to give you any EKGs on the video or on your exams. Okay. I'll just verbalize things for you, but I'm not going to give you any EKGs on the exam. If you're ready for something like that, I think it's too involved. Okay. So I'm not going to give you that. But you should be able to understand this, and the EKGs are there as illustrations to reinforce what we're talking about. Heart block, there's a whole slew of different heart blocks. I'm not going to get into all the details of that. It's just not worth it right now. Just understand what a heart block is in general. A heart block is, if you know the electrical impulses going from the SA node to the AV node to the bundle His to the two bundle branches left and right to the Purkinje fibers, anywhere where that gets disrupted will lead to a heart block. You're blocking the heart electrical impulses. That's what heart block is. Okay? So that's what's going on there. If you need to review that order, you should know those orders. SA node, AV node, bundle His or atrioventricular bundle, same thing, to the left and right bundle branches down the interventricular septum to the Purkinje fibers. Again, all of that is in the first 50 or so slides of review of this PowerPoint. Okay? And then we have asystole. Systole means contraction. If you put a prefix there, a, then that means without. So this means without contraction. Okay? This usually refers to ventricular asystole. Okay? The ventricle doesn't contract. And what it looks like is normally you're going to have you have P, Q, R, S, T, right? And then you have P, Q, R, S, T. But in person over here, you will have P, Q, R, S, T. And then all of a sudden, no contraction. That's what you usually hear. Right, in all those TV shows, the movie and stuff. There's no contraction happening. Asystole, not a good thing, right? Your heart just stops, okay? So that's cardiac arrest, that's a myocardial infarction, all right? That usually will cause that, okay? So it's complete absence of the heartbeat, okay? And again, these are just showing you some other, there's tachycardia up there, ventricular fibrillation is happening here, I just showed you that from before. Heart block, you'll see things like, here's a P, Q, R, S, T, P, they skip the beat. There's something going on because there's some sort of blockage between the electrical impulses from the SA node to Purkinje fiber. The P should be a QRS, but it's not. You got a P, QRS, it's not there. There's a P, QRS, P, and skip. So it's like skipping a beat, so to say. But again, I'm not going to just understand what heart block is all about. I'm not going to ask you about all those different types. The book goes into those different types. First degree heart blocks, second degree, third degree. Don't worry about all those. Just understand what heart block is. Okay? And that's it.